Hello, and welcome to Therapy Coverage, Barriers and Opportunities for Chronic Conditions. This presentation will provide an overview of how health coverage of therapy can lead to barriers to care, especially for persons with chronic conditions. My name is Kate Gilliard, and I'm Director of Health Policy and Payment at the American Physical Therapy Association. I'm joined by Laura Broyles-Hooper, Manager, Health Policy, State Affairs Group with the American Occupational Therapy Association, and Rebecca Bowen, Director of Healthcare Policy, Value, and Innovation with the American Speech Language Hearing Association. Part 1, Introduction and Barriers in Benefit Construction. So in order to sort of set the table, let's discuss the traditional benefit designs for therapy. Traditional Medicare or Medicare fee-for-service is usually a benchmark for most American health plans. So let's start there. Until 2018, there was a hard cap on therapy benefits. This was a dollar amount limit, after which no additional therapy services could be billed. The cap was difficult for providers to comply with, as they needed to ascertain if their patient had received therapy services from another provider or discipline, and exactly how much had been charged. Additionally, the cap was applicable to combined speech and physical therapy services, while occupational therapy had a separate cap. Fortunately, after years of advocacy by APTA, AOTA, ASHA, and their members, the cap was repealed in 2018. However, therapy providers are still subject to certain limits that look quite similar to the original caps. The so-called therapy thresholds are not hard caps, but retain the dollar limits of the caps, after which providers must append a KX modifier, essentially an attestation that the patient needs additional medically necessary services. These thresholds maintain the odd combination of PT and speech in one bucket and OT in a separate bucket. This is unfortunately the result of a missing comma in the phrase occupational therapy, physical therapy, and speech therapy, leading CMS to assume that Congress intended speech and PT to be lumped together. For 2023, the therapy threshold is $2,230 for PT and speech combined, and a separate $2,230 for occupational therapy. Any amounts billed in excess would need that KX modifier. In addition, there's a medical review threshold of $3,000 that any claims that go above that amount for an individual beneficiary could potentially be subject to medical review. So it's not guaranteed that a review will occur, but there's an increased likelihood. Accordingly, therapy providers still need to ascertain how much therapy their patients received in order to know when to append the KX modifier. Now, unfortunately, because therapy thresholds look so similar to therapy caps, misunderstanding of the policy persists. Many providers mistakenly believe the thresholds still operate as hard caps, or that the increased likelihood of a medical review is reason enough to forego providing additional services to beneficiaries. So this can have a serious consequence on beneficiaries who need these services, especially those with chronic conditions who may need continued services from multiple disciplines for extended periods of time and potentially year over year. So this policy is also very incongruous with coverage for maintenance therapy, which only became a covered benefit in Medicare via a lawsuit, not an act of Congress. However, the very nature of maintenance therapy, which allows for treatment to slow decline or maintain function rather than treatment to improve it, means therapy patients who need it will almost certainly reach these thresholds year over year. Keep in mind that all this applies to traditional Medicare. Medicare Advantage, which is Medicare administered by private insurance companies, is a whole different story. Medicare Advantage has to cover at least as much as traditional Medicare does, but it gets trickier when benefits are actually implemented, and billing and payment processes can vary greatly with Medicare Advantage plans. The next place to look for benefit construction standards is the Affordable Care Act. The Affordable Care Act requires non-grandfathered health plans in the individual and small group markets to cover essential health benefits, or EHB. These include the item and services in the following benefit categories: ambulatory patient services, emergency services, hospitalization, maternity and newborn care, mental health and substance use disorder services, including behavioral health treatment, prescription drugs, laboratory services, preventive and wellness services and chronic disease management, pediatric services, including oral and vision care, and rehabilitative and habilitative services and devices. Naturally, therapy providers and advocates are extremely supportive of the inclusion of rehabilitation and habilitation as its own EHB category. The guarantee that all individual and small group plans at least provide basic coverage for these services is critical. However, the ACA does not require plans to cover EHB categories without limit. Plans are required to include at least as generous a benefit as is provided in each state's benchmark plan. And those benchmark plans vary from state to state. So while plans may not impose annual or lifetime limits on spending, plans are permitted to include certain types of benefit limits that can be found in the benchmark. So most often, these limits are hard caps on visits and often group the therapy disciplines into one bucket. For example, a plan may limit rehabilitation services to 30 visits a year, PT, OT, and speech combined, and sometimes even other services like chiropractic or acupuncture are included as well. These limits, unfortunately, often do not account for persons who experience distinct events or diagnoses that require different episodes of care or different disciplines of therapy. For example, it's not hard to imagine a beneficiary having an injury in the early part of a year and needing rehab therapy, but then later in the same year experiencing a separate event, say a stroke, that requires additional intensive therapy from multiple disciplines and quickly reaching their 30 visit a year limit. Additionally, persons with more predictable needs may be forced to make decisions between 2 or more therapy disciplines, as their benefit limit may not allow for them to obtain all of their necessary services. One silver lining, and a particularly noteworthy aspect of the ACA, is the fact that it distinguishes between habilitative and rehabilitative services. Habilitative services differ from rehabilitative services in that they are designed to help patients acquire skills and functions for the first time, while rehabilitative services aid in regaining skills or functions that may have been lost. This means habilitative services are extremely important for persons with lifelong disabilities or congenital conditions. The ACA requires plans to keep those benefits separate, which is done by appending a modifier to claims for habilitative services. The ACA also prohibits plans from placing limits on habilitative services, which are more restrictive than rehabilitative services. Moving on to Medicaid. While Medicaid, of course, covers many more beneficiaries than Medicare, due to its nature of being a federal and state partnership, the variability in benefit design is immense. First, for the adult Medicaid population, rehabilitative and habilitative services are not required to be covered at all. It's entirely up to the state to decide whether or not to include PT, OT, and speech, and what limits will be implemented on these services. While the vast majority of states do cover all 3 disciplines, the fact that the services are optional means states, in times of financial stress, may opt to drop them. We saw that exact thing happen in Missouri in 2005, when coverage for PT and OT was dropped. And it wasn't until 2019 and the worsening of the opioids epidemic that finally motivated state policymakers to reinstate coverage for therapies. Fortunately, the EPSDT benefit is mandatory. This early periodic screening, diagnosis, and treatment benefit is available to all persons aged 21 and younger, and ensures young persons are able to routinely be screened and treated without limit. Because of its lack of limits, the distinctions between HAB and rehab and the 3 therapy disciplines is less consequential. One interesting fact about the EPSDT benefit is that it was created in response to a 1964 government study that analyzed why 50% of men drafted into the military were rejected. The majority of young men rejected for compulsory military service failed as a result of physical and mental health conditions, which could have been diagnosed and successfully treated in childhood. So the origins of this benefit are really a national security rather than public health. Finally, you can't talk about Medicaid without mentioning Medicaid managed care, which really operates more like commercial insurance, similar to Medicare Advantage. The barriers in these plans vary greatly and will be discussed in more detail in part 2, but things like utilization management, narrow networks, and other barriers to care are systemic issues in these plans. So in sum, the barriers to care begin in the benefit policies themselves. Basic coverage of services isn't guaranteed in Medicaid, which covers over 85 million people. But fortunately, half of those enrollees are children who are eligible for EPSDT benefits. Yet, even when covered, limits in benefit construction can seriously limit access. Limits on the number of visits or the dollar amount spent can force beneficiaries to end care sooner than they need to. Additionally, provider apprehension concerning exceeding limits and therefore not being compensated or subjected to audits further reduces access. Finally, when limits combine therapy disciplines or don't allow for distinct limits for distinct diagnoses, patients may be forced to choose which type of therapy they will receive or which type of illness or injury they will seek treatment for. People with chronic conditions have a higher likelihood of being forced to make these unfortunate decisions due to the very nature of their condition. And that's the end.